Seatbelts.
Yep. Just let our attendees enter here at the top of the hour.
Hope we get some.
Yeah. Hi, Daniel and Claire. Or otherwise, we'll just have a wonderful conversation, but we've got some people heading in. Hi, Christopher and Claire and Daniel and Divis and Eugenie. Hi, Kirby and Penyote. And hi, Shanda. Hi, Penny and Reza. Hi, Vicky. Hi, Lohi. I see Grace is here, so I'm going to promote her to panelist. Hi, Cindy. So wonderful to have all of you join us. Welcome to the OUM community and welcome to Meet the Dean and Associate Dean of Australia. We're so happy you've joined us, and I'm so happy to be able to welcome Dr. David Mountford and Professor Paddy Dewan as our panelists today.
Well,
Thank you so much for joining us. So I'm going to be asking our Dean for Australia and our Associate Dean for Australia a series of questions to help you get to know them better and to help you get to know our program in Australia a little bit better. If you have a question, feel free to type it into the Q&A box and we'll choose a few questions to answer live. If we're not able to get to your question live today, we'll make sure to connect with admissions counselors and get that question answered and back out to you. So thank you all so much for joining us. We're happy you could join us in the OUM community today. I'm Associate Professor Nicolette McGuire, and I am our Associate Dean for Student Engagement. And I'm also our Deputy Director for Preclinical. And you may have met me before if you've been to our webinar series. And if you're brand new, welcome. And we're glad that you've joined us. So I'm going to start with you, Dr. David Mountford. Could you introduce yourself to our attendees? Let them know a little bit about you.
Oh, hello, everybody. It's morning here in Brisbane. I don't know what time it is in your place. I've been a medical practitioner since 1976. I did some rural time in the country. In those days, if you didn't have a scholarship, you could get one through the state government we have here in Queensland, but you had to go to the country to repay it. So I spent nearly 4 years in the country and came back and started general practice in Brisbane. I was in general practice the whole time, had some very interesting experiences in medical education as I went through, working for the different universities here in Brisbane. And then luckily one day, our previous Vice-Chancellor, Professor Bartholomew's, rang me up and said, we need somebody to help with the OSCE next Saturday. Yeah, could you come along? And that introduced me to OUM, and I've been there ever since.
We're glad to have you. And for those attendees who don't know, OSCE is the final clinical examination. It stands for Objective Structured Clinical Exam. And you may have a few questions about that, and we'll ask Dr. Mountford later on to talk a little bit more about that. Always an exciting time for students as they get to the end of their medical education in school. Definitely not the end of their medical education overall. So yeah. Professor Paddy, would you like to introduce yourself to our attendees?
Yes, thank you very much, Nicolette. It's a pleasure to be here and to hopefully excite students to enter the medical course and to progress through the course in a very positive way. There's lots of stress along the way. It's a hard road, but it can be a very enjoyable road. I'm a paediatric urologist as a subspecialist, and I spent a lot of time in research, not because I was particularly interested in doing research, but what I found was that there were so many questions that didn't seem to be adequately addressed. So in one condition that I've done research for, psychoureteric reflux, it's been known since the 1950s, but we just still don't understand. So my PhD on that subject actually says, my PhD has expanded my ignorance. And how did I get involved in becoming a medical student? I actually wanted to be a vet. came from a country location, and so it had a lot to do with animals and farms, and so I thought veterinary science was where I might want to go. And somebody asked me the question, why don't you do medicine? And I couldn't answer it, so I did. But I'm very glad I have. And my journey is possibly not nearly as interesting as many the students who come into OUM. You've got some marvellous stories of achievement and diversity and the ability to change over time. And that's really important to doing medicine and being a medical student. So I came into medicine, thought I was going to do general practice, and particularly because I was running children's holiday camps, diabetic camps they were, I chose to go to a country location for my residency, my intern year, because otherwise I was going to have to miss out on going and teaching kids how to look after diabetes as when I was going to be a first year resident. So having done that, I then realised that connecting with children through these camps, really working with children into the future was what I wanted to do. So I then decided to seek a paediatric training position. And then another statement was said to me by a surgeon, I think you'll find it hard to put the knife down. I remember a guy called Robert Fowler, an eminent surgeon in Australia. And so with that stimulus, I realised that I could do both working with children and surgery. Having a mother who was a handcraft shop owner, I became very good at suturing, so it was an easy skill to progress as a surgeon, and thus I've become a paediatric surgeon. With OUM, it was from contact from a very good, very enthusiastic student who was the daughter of a GP who was referring me patients. And eventually, after she nagged me a couple of times, I said, "Oh, right, I haven't heard about OUM, but yeah, come on, you can do a rotation with me." And it was a magnificent experience with a wonderful young lady who's gone on to be very successful, as has her mother as an OUM student, by the way. And since then, I became the state coordinator for the organisation of rotations, and then took the opportunity of taking up the dean position, which I thoroughly enjoy, the ability to have some influence over the university into the future and to connect with students who, I think the students are why we're all here, because you guys are so refreshing. It's so exciting to think of the influence that you're going to have in medicine into the future because of the model that we have that creates such a stellar ability to influence the future. So welcome all.
Thanks, Paddy. I like hearing about how your career just expands as it goes along. Your reach just gets wider and wider. And you were talking a little bit about one of the things that you liked about OUM was its diversity and the stories of the students. Do you want to say a little bit about that, knowing that you've worked in a lot of different areas in Australia and in different areas of medicine, but is there something about the diversity at OUM that you can put your finger on?
Yeah, and that's why I think, because you people have come to medicine through different pathways than being in high school, being in secondary school, and then coming into medicine as where to go to first. You've had a long time to think about where you might want to be, and you develop skills in pharmacy, in physio, in nursing, etc., that actually value adds to your ability to care for patients, because it's that caring for patients that's really important. The academic knowledge is vital to being able to do it well, but if you're not developing an attitude and an approach that's caring, then you can't do that. So I think that's a really valuable thing to do in medicine. I think there's the previous approach of saying, I want to do medicine, I'll get into medicine without having any life experience beforehand, has actually not been good for medical care previously. And the OUM model of taking people who have that experience, have that knowledge, and can share it with others. So the students who have been in pharmacy, for instance, can help upskill other students in matters pharmaceutical. Those who are upskilled in physiotherapy, there's a lot, the physical management of the patient has a lot to do with their welfare, and having physiotherapists in their previous career part of the student cohort, it expands the impression of the importance of that. And likewise for nurses who've been involved in psychiatry, for instance, the importance of the aspects of psychiatry in medicine in general and its big impact in general practice. That sort of diversity, I think, it's uplifting for everybody. So we're working together, and whenever you're working with somebody else, you tend to perform better. And when those people have got skills that you aren't so strong in, it increases the overall level of those skills in the group. So it really is, it's great to see. And I learn a lot from students as well.
Professor Paddy. Dr. David, I want to talk to you a little bit about that caring aspect, because I know that you do a lot of work with our students in developing their skills in that area. But there's one thing I want to ask you first, which is you mentioning that you started your career as a rural physician. And I know that's an area for you of high importance and an area that's of importance to me as well. So did you want to just speak a little bit about your thoughts around the need for medical students and clinicians to have rural medicine experiences?
Oh yes, it's you know, when I graduated, I knew I had to go to the country. That was, but being a city kid and married to a city kid, it was sort of, oh gosh, well, we've got to do this sort of thing, and you know, it's going to take a chunk out of our lives. Well, it was totally the opposite. It was totally the opposite. It was so wonderful to work in the country. It was just great. I worked in a little town northwest of Brisbane, 2.5 to 3 hours drive away, called Kingaroy, and I was working in a 2-doctor public hospital. It was an extraordinary time. The amount of stuff you learned was quite incredible, and you learned it at such an accelerated rate compared to you would learning it in a big city hospital. The amount of responsibility that we had to undertake at that very young age, you know, 1 year graduated, was extraordinary. You know, there was no other show in town. You were it. I was saying yesterday to one of the students we did an interview with, I was in Kingaroy for nearly 4 years, and on 2 occasions in that nearly 4 years, I worked 96 hours straight by myself, which is from Thursday morning around 9 o'clock through till Monday morning without a stop. And I remember taking a patient down to Brisbane by ambulance and then coming back at 3 o'clock in the morning. I think it was on the Saturday morning, I'm not sure. And I got out of the ambulance, and one of the nursing sisters ran up to me and said, "Thank God you're back. There's a patient on the roof who's going to jump off."
Oh my gosh.
So there were quite amazing things. And as part of that too, I think as young doctors, we're so proud of ourselves for having learnt the science and gone through studying our clinical medicine and learning some things about clinical skills. But then when you get in a situation like the country, you really have to accelerate that very quickly. And you really do learn how to listen to people properly. And you really do learn how to observe them properly, which is really very, very important. They're the 2 most important clinical skills you can have. If you listen well and you observe patients well, they're the best skills you can get. So coming back to Brisbane to do general practice, I thought would be a bit of a yawn. But again, I was very surprised at how difficult it was to start off with. And as the years went on, the beauty about general practice is you become engaged in the care of different people over different periods of time. So, you know, like all young GPs, I've had a lot of paediatrics to start off with. We had a pandemic of heart disease going around the world at the time, so there was a lot of cardiology. And then in later years, there was palliative care, and there are a lot of other things that you can become involved with as a GP. And the reason why you actually do that is so that you can care for people totally appropriately for the situation that they're in.
A real diversity of clinical experiences over a lifetime of a career. It's amazing. And I know Oh, sorry, go ahead, David.
It's actually been wonderful. And one of the questions that you asked here, how's being a doctor different to what we dreamed it would be? And you know, like I said at the last meeting, I was always going to be a plumber like my father, until he said to me one day, and to my twin brother, do whatever you want to do, don't be plumbers. And he got very sick, and he needed an aortic valve replacement operation. And we used to go up and visit him of a night time in the hospital, and somebody left a stethoscope hanging over the end of the bed, which was never done in those days, never done. And I was a bit of a strange fella, so I picked up this stethoscope and put it on his chest and heard a human heartbeat for the first time in my life. And it was transcendent experience. You know, from that second on, I just had to be a doctor. There was no other alternative. So what is it about medicine? Is it just becomes part of your life. You live and breathe medicine. You know, you can be at a family engagement or something like that, but sometimes at the back of your mind, there'll be the patient you saw during the week that you weren't quite sure about, you know, and you're thinking about it, and all of a sudden, bing, a little answer will come into your mind. So, you know, I suppose I'm just so glad I was given the opportunity to do medicine, to become a doctor, and to have the life that I've had, caring for people in their own situations.
And now caring for our students too, which is fantastic.
Which I just love, yeah.
I remember having a conversation with our clinical coordinator for Queensland, and he says, like, even when he goes to the grocery store, he's like thinking about people in the grocery store and ailments that they might have and how he might help them. So it's like it doesn't, you know, you don't close the door to your office and suddenly you're not a doctor once you're a doctor. That's your whole mindset, your whole way of thinking. Yeah. Paddy, I wanted to ask you, because we were talking a little bit about rural placements with Dr. David, and I know you've recently returned from Samoa, and all of our students at OUM have an opportunity to get this fantastic clinical experience in Samoa, where they get to do a number of things that they wouldn't otherwise in their placement in Australia. Do you want to tell our attendees a little bit about our rotations in Samoa and what that's like?
Yeah, I've had 2 trips to Samoa with 2 hats on, both the OUM hat and Kind Cuts for Kids, which is the charity that I'm associated with, and going there to empower people to not only connect to the patients and do the right thing with the patient who's coming to them, but have that sense of community connection about the problem. So early diagnosis is made by making sure the community knows when to come along. And so in going into that sort of environment, as a surgeon doing detailed surgery on small people, you take a kit of instruments. So a couple of suitcases is satisfies, because you need to learn to work with the local equipment, the local team, and fit in with the people who are there. So it is different. Samoa is a developing country, but the accommodation is a little bit different. The hospital and the facilities are different, so you need to fit in. And I use some terms that are helpful, and that is first seek to understand. So if you're going to Samoa, which you need to do, it's part of your obligation as an OUM student, and it's not an impost, it's an honour to be able to have an opportunity to go and to work with this beautiful Samoan people who are very caring and compassionate, but with a lot of illness that we need to help them deal with it. So first seek to understand, and then the other term that I use in that sort of environment is, why is it so? And there was a chap called Professor Julius Sumner Miller who ran a children's science program on the ABC here in Australia back in the 60s. And that was the question he posed. In fact, it was the title of his show. So why is it so? And using those, not only when you go to Samoa, so first seek to understand, why is it so? I think they're part of the ethos that creates that sense of caring And that's what you need to do when you go to Samoa. Don't be judgmental of what you might see. Seek to understand and wonder why it is so, if it's different from where you come from. The other thing I'd like to add about the caring thing is when you're going into a clinical environment and you're meeting your patients, regarded as meeting experts. The family that you meet as a paediatric orientated practitioner, I am meeting with experts. They have expertise about the children that is superior to any expertise I would have about their children in some regards. So if you want to be caring for your patients, see them as a partner in the healing process that you're a significant contributor to, but they're also a leader, they're an expert in that as well. So I commend to you the honour you have of being able to go to OUM, and we also have contacts around the world where you have time to do elective, and I see there's a question about the rotations. There are 16 weeks when you enter the clinical arena of electives, and they can be in inventive places. For instance, we've had one student from New Zealand who was able to take the opportunity of having a rotation to Kosovo and subsequently took the opportunity of doing another elective in Kosovo because the experience was different, broader, more hands-on participation. So those sorts of opportunities are available around the world. While you need to get the skills to work in the country in which you're graduating, you can also reach out and have other opportunities to enhance your skills as well.
Professor Paddy, you mentioned kind cuts for kids, and I wondered if you just wanted to chat a little bit about that. And I know some OUM students have been able to gain some experience working with you in kind cuts for kids. So maybe you'd like to say a little bit more about that for our attendees so they can have a little more information.
Yeah, and also from the point of view, thank you very much, Nicolette. If you are involved in medicine, it's a giving profession. But you get back far more than you can ever give if you take that opportunity. So Kind Cuts for Kids is about giving back to the rest of the world, but it's also about enhancing the ability to contribute to medicine through seeing a wide range of pathology. So, for instance, one of the things that's happening at the moment is Patrick Mill is one of the students who has dived into the database that we've accumulated since 1993, and there are 9,000 lines of data, and he's looking at the anorectal anomaly, the imperforate anus, so children who are born without a bottom, and a condition where the nerves down the bottom end of the bowel are abnormal, Hirschsprung's disease. So he has got an enormous project that he's able to do that will make a very significant difference to his career through him going through that work, but also a significant impact on the development of understanding of the care of children with that condition, not only in developing countries, but also for developed countries because of the lessons learned through the complexities that we've encountered in those circumstances. So we've had visits to 22 countries since 1993, and as you hear, there's 9,000 lines of data on more than 5,000 children. So again, I would commend to students, once you develop the skills, find an opportunity to give back and you'll get even more out of your medicine.
Thanks, Professor Paddy. Dr. David, I want to go back to you now and ask this question about caring, about giving and caring. Is that something that we teach? Is that like an inborn talent and skill that medical students need to have? What are your thoughts about the essential nature of caring and giving in a medical student?
It has to be part of your soul that you care for other people. We're now doing the interviews for people who are applying to OUM to come and study medicine with us. And, you know, they're an incredible group of people. The last 3 times I've done interviews, I've been amazed by the people who've come along. But the most extraordinary thing and the thing that makes those of us who are panelists happiest is that these people care. They're coming along to us. They want to do medicine because they have a deep caring for doing well for other people. They want to be of service to other people. They want to be of help to other people. I think Paddy and I would have in common the fact that we have met uncaring doctors in our lives that we've had to work with on occasion. And I think one of the most intolerable things I've found in my working life is working with uncaring doctors. It shocks me that people can approach another human being in an uncaring manner. And I find it singularly unjust. There's a whole range, unethical, everything. So I think what happens with us as we grow in our lives through medicine, as we go along and get exposed to more and more different things, the depth of our caring, or our ability to care, deepens and deepens and deepens. So when I was a very young doctor, I used to ask myself the question, what would have to walk through that door to frighten the pants off me? So that I would stimulate my mind to think about things that I didn't know. And the first set of things that came up to me was, if two parents came into me crying one morning because their child had died of sudden death syndrome the night before, I simply would not have had an idea of how to care for those people. So I went and learned. It's as simple as that. The best years of my working life were spent in palliative care. And that, I think, is a deep, rich area of medicine. If we look at orthopedics, you do a knee replacement, you do a hip replacement, something like that, the caring is within a limited range and things like that. With palliative care and with a whole other subsets of areas in general practice, there is this ability to explore yourself further and find out how deeply you can actually care about other people in a personal sense and a professional sense. And if you don't have a caring attitude, you're not going to make a good doctor. Your patients are not going to be happy with you, and they vote with their feet.
If I can just reflect back on it's not just that you're a caring person. It's that you have an active drive to care that pushes you into an area of discomfort, that pushes you to learn more so that you can help people before you even know who they are or what their problems are.
We were talking to a student yesterday about medical ethics, about a patient's autonomy, which is not properly understood, beneficence, non-maleficence, and justice. They're the four ethical pillars on which medicine is based. And I won't go into autonomy, but I want to talk about beneficence for a moment. Beneficence basically means, well, it used to be thought to mean to be kind to a patient. But the people who've looked at the ethics of medical practice say, well, that's just not good enough. Basically, even if you see a person with a cold, an act of beneficence will make them leave that consultation feeling better. They will feel that they've been heard. They'll feel that, it's only a cold, but the doctor was attentive and the doctor cared what was going on. So, as the years went on, I got this very strong understanding that it wasn't just treating the problem that was there or anything like that. The patient had to leave the room feeling that, gee, I really benefited from that in so many ways. But most importantly, I like them to walk out feeling like that man listened to me and he really understood what my concern is.
Paddy, I wonder if you have anything you wanted to add to that. You look like you have something that's important for us to know.
Yeah, I agree that the whole sense of caring is so vitally important, and you can be a caring person, but I think you can also learn to care by observing the clinicians that you're working with in the clinical setting but also through the lectures that are given in the preclinical area and in David Mountford's transition clinical skills course, learning the skills and such as reflective listening is one of the ones where by demonstrating that you're hearing what the person is saying, as David was suggesting, that people need to know that you have actually understood. But I think even going that extra step, and when you see the distressed look, the lack of reassurance from your discussion, you actually reflect to the patient, the parent, that you still don't look comforted by what I've said, if you're talking about an operation, for instance. And it is amazing how much conversation you open up with that sort of reflective body language and reflective language. It makes them able to feel heard, and material that they thought, oh, I'll sound stupid if I say that. You often hear patients say, but once you say, no, I want to hear everything you've got to say. I have had occasions where I've completely changed my tact on where I should go with the patient after I have made that sort of, yes, please give me more. It looks like you've got more to give me than you're actually saying at the moment. And finding that you've changed your diagnosis completely because it said, you don't look comfortable with my conclusion.
We were talking about this clinical skills course before the webinar started, and we're kind of brushing the surface of it right now. So I just want to dive into it because I know that our students who have now completed their preclinical medical sciences courses and have taken their preclinical exam, they're about to head into what we call our CSC, our clinical skills course, starting in April. And a lot of students prospective students are curious about, how do you learn clinical skills in a hybrid university where some of the content is online, some of it is in virtual classrooms, and some of it is in person. So I wonder if you would like to say a little bit about the clinical skills course. What types of clinical skills do we teach our students? What's the structure of that course? So maybe I'll start with you, Dr. David, and then Professor Paddy, I'll ask you to fill in some additional details.
The clinical skills course that we've developed now in Australia starts off with a 5-day face-to-face. That's usually what happens. We have students who finish their SPMs, done their PCE, and they then have to do a clinical skills course. So we usually start with a 5-day face-to-face, and during that 5-day face-to-face, we introduce them to do what it's like to be a doctor, how doctors behave, how doctors think, the moral and ethical aspects of it, just the simple things about, the simplest but most powerful, actually listening, reflecting on what somebody's told you, like Paddy said, looking at the patient, observing them, seeing the look on their face, the look in their eyes, whatever's going on, noticing changes that happen during the consultation because of what you may have said or because of what you may not have said. We teach people how to take a medical history. We teach people how to take that information they've learned from their clinical history, and they add to that the knowledge that they've already accrued for learning normal physiology, biochemistry, stuff like that. Then they learn the pathophysiology. At that stage, at the end of your 2 years of preclinical work, if somebody said to you, now you've done all this science, do you think you'd be able to go out and be a doctor? The simple answer is no, you can't, because you haven't been introduced to the art of medicine. And the art of medicine has a lot of different factors to it, involving, personal skills, metaphysical skills, cognition, a whole range of things like that. And as the 5 days goes on, we introduce you to those sorts of things. We introduce you to the way medicine changes depending on the specialty that you're dealing with. So we have a paediatrician who comes along, we have a psychiatrist who comes along, emergency medicine physician, and we have surgeons who come along who talk to us about doing surgery and teach you how to stitch, how to do stitching. We teach you how to put an IV line in. We teach you how to examine patients, how to elicit physical signs. Then we teach you how to put that together with the history that you take from the patient, plus the information that you get from the examination. We start you along the difficult path of establishing what we call a differential diagnosis. In other words, what's wrong with this person? What is present that I may have to do something about? And in general, we try to keep that down to about 3 things in the clinical skills course. It could be this, it could be that, or it could be something else. And how we differentiate those things through. And then we talk about how we manage patients, how we actually talk to patients about what we think the problem is, whether they agree with our thoughts, and we try to come up with a plan together on how best to approach the management of the problem. So that's about what happens in the first 5 days. Then we have 2 weeks of radiology, which Paddy and his team look after, where you'll be taught how to read x-rays. When I first became involved with OUM, somebody told me that they were doing an OSCE right at the end of the course, and they flashed up a chest x-ray for a student to have a look at. And the student didn't know what it was, didn't have a clue it was chest x-ray. What's going to happen when you go through your rotations is that the consultant that you're dealing with will flick up an x-ray in front of you, or will hand you a blood test and say, what do you make of that? And you'll have to interpret it. So the first part of that is you learn the basic radiology that you're going to need to do your rotations, which will help you then with your internship. And then we teach you some pathology, how to deal with pathology results, the full blood count, the biochemical profile, things like that. And then we have, for the rest of the weeks, it's an 8-week course. We do a lot of case studies, and the clinical skills course is built around cases, because the best way to learn medicine is by being exposed to cases. And you can teach each other a lot about that as medical students, because you'll be doing your rotations. You would have sorted out a group that you belong with, because you all entered the course at the same time. So you'll be in a cohort. Please tell each other about the cases that you've seen, because you'll teach other people so much medicine just because of your experience with a case. So cases are extremely valuable. So that's basically what the clinical skills course is all about. Can I just say, if you want to, there's a book called Every Patient Tells a Story. It's by Eliza somebody or other, I've forgotten her surname. It's a paperback, it's been around for ages. She's a very, very good, extraordinarily good American diagnostician, and she's famous for it. What she's second most famous for is that she wrote the scripts or the medical situations in the Dr. House TV series. Those of you who have not seen Dr. House, the TV series, it was in the 1990s, and she wrote it as him being the worst type of medical practitioner you could ever come across in your life. He was a horror. He knew all the diagnoses, he knew all the rare tests to do, but he was a shocking person. And she wrote those scripts basically to say to people, well, it's not the smarts that you actually need, it's the caring smarts that you actually need.
Dr. David, there's a question in our Q&A, just confirming, is the clinical course face-to-face? And are there other courses we can sign up to or join during year 1 and 2 of the preclinical so that they're prepared for the clinical course?
It's a hard one to say. In the new med science course, which everybody's will be doing from this year and last year, you will actually be taught some clinical medicine as part of your learning about cardiology, respiratory disease, gastrointestinal problems, things like that. So you will have some contact with clinical medicine. I don't think you can actually read clinical medicine out of the book. I think you actually have to hear it demonstrated. I think you have to see doctors who've actually worked in medicine for a while, telling you of their experiences, how we interpret this, how we interpret that, things like that. There's an awful lot of person that goes into clinical skills. So I don't think that there's a way that you can learn clinical skills well in your preclinical years. Your preclinical years are very heavy work. So I would be inclined to focus on that first, to make sure you do your preclinicals well. And then when you come to the clinical skills course, all the way we'll go. But yet 5 days face-to-face, an 8-week program all up. The rest of it's done online. So I suppose that's the best I can say.
Yeah, the preclinical clinical skills are more about providing context for the information that you're learning, so you know how to apply it, but it's not to the depth that you will get in the clinical skills course by any means.
If you go to the clinical skills course webpage, I think it's on Moodle, I think. I'm pretty sure it's there. There's a thing that we send to people to say, welcome to the clinical skills course. Here's your pre-reading, and there's a list of books there, okay? There's 2 textbooks, and there's about 6 paperbacks. And the paperbacks are books I've read all of them, and they just look at what life is like as a doctor from a lot of different perspectives. And I think if you're interested in clinical medicine and you sort of think, all this science is getting a bit dry, I'd like to have a drink from the well of clinical skills, have a look at some of those paperbacks. Some of them are actually quite extraordinary, and they will give you that feeling of medicine, that, you know, the care that's involved with other people.
If any attendees are interested in that list, just let your admissions counselor know and they can provide you with that information. Professor Paddy, is there anything you'd like to say about clinical skills? I want to ask you about clinical rotations as well, but is there anything you want to add?
So just going to the book that David mentioned, the subtitle is Medical Mysteries and the Art of Diagnosis. David Mountford also mentioned learning the art of medicine. And I think that's very much so what the clinical skills course is about, as is the preclinical to some extent. But I regard surgery, for instance, as the artful application of science and the scientific application of art. And I think that's part of what you learn through the course, and particularly through the clinical skills course. But in terms of, if you have an interest in something in particular, so if you've decided coming into medicine, you want to be a surgeon, you can actually find a lot of material on the internet that teaches you how to tie the knots, teaches you how to suture, and then that can be, you can fact check that through the clinical skills course. So be skeptical about anything you read on the internet. It's not the truth. It's a way to find questions, not answers. But there's a lot of material. For instance, if you want to be a cardiologist, you can go and you can learn a lot about ECGs by using the internet and using the material that OUM provides. But if you've got a real passion for doing something in particular, then go off and enhance your skills in that way, because there's a lot of material that is additional to you. So don't be constrained in your information gathering, but be certain that you're fact-checking about whether it's good quality information that you're actually getting hold of along that journey. But be excited about learning more. Don't restrict yourself to what we're giving you.
All about lifelong learning. Professor Paddy, I want to ask you about clinical rotations. As you may want to know, my first question is about clinical placement. I would like to know, OUM partnering or associated with any hospitals, in Australia and tell us a little bit about the fees. So let's talk a little bit about clinical rotations. What can Australian students at OUM expect once they're finished their preclinical science classes, once they get through the clinical skills course? They're ready for clinical rotations. So what should they expect?
Right. So there's 56 weeks of core rotations. So that's the essential things that you need to do in the different specialties of internal medicine, of surgery, emergency medicine, pediatrics, etc. And they're broken down into different aliquots. And usually, if you're doing a rotation in as a section, so you might do a rotation in pediatrics in my clinic, which is 2 of your 8 weeks. So that's a segment of a complete rotation. Those rotations, half of those rotations can be in Samoa. So if you want to do half of your pediatrics in Samoa, you're able to do that. So that's an arrangement you can have. And in terms of, and the 16 weeks elective are what you would like to do, but we try and give you some direction about what you might do in order to make sure that you're well trained to do the exam and well trained to work well as an intern. So for instance, if you do your core community medicine with a practitioner who has a relatively small practice with maybe 1 or 2 GPs, then we would suggest that you don't, although you get on very well with that person, rather than doing an elective in community medicine with that practitioner and that practice, that you find another, so you see a different profile of practice. You reach for further understanding through having contact with other people. So there's an advantage to spending even more time with the same practice, same practitioner, but there's even more advantage to reaching out to see how things might be done differently, so you expand your learning. So the way we go about it, so they're the rotations are in usually close to home. Sometimes in order to get a rotation, you may have to change state. So we have a very good resource, and you're asking about association with hospitals. A network in South Australia takes 10 of our students at any one time with fees that are higher than most other rotations. So there is an additional fee that you need to pay, but the rotations are superb and absolutely lauded by the students who go. And in terms of the partnerships with hospitals, not very long ago, we were engaging the students to engage with the rotations. OUM has come of age since then, and it is now, there is a partnership between the students and the organisation, but the management of the rotation procurement is through the management system within the university. So the rotation coordinators in the office in Brisbane, with the management team in Brisbane, with the assistance of the rotation coordinators in each of the state jurisdictions, of which I cover 3 of them. And so what is happening very much now is that developing of an association between the OUM organisation and the principal organisations around Australia is what's happening. There's a large body of work being done at the moment, and at the pointy end of that development, there's an association with the Ramsay network, so it's an Australian-wide network, but also the other networks of St Vincent's, St John of God, Healthscope, Cabrini, Wesley. Each of those are organisations that we're going through the process of developing memoranda of understanding, where there's a second body of work being done by the clinicians, which is connecting to the clinicians within that organisation, because if we don't have the buy-in of the clinicians in those private hospitals, then the association with the organisation doesn't actually deliver for your students. So if you have connections to healthcare practitioners who you might want to go and do a rotation with, what you need to do is to give that information to the university and work with the university mechanisms to see that that might happen. Going off and developing something where perhaps there is history in that direction that you're pursuing that is problematic, then that can actually result in compromise of you as the student's position and compromise of the university position. So, for instance, we've had circumstance where we've got public hospitals where they don't accept OUM students because they're associated with the university. But if the student happens to be the offspring of 2 consultants working there, then sometimes we actually get a lot of rotations into that organisation. So we have little avenues that expand our opportunity. And one of those needs you as students to do some of the groundwork, and that is getting into the inbound electives, they're called. This is where you go to a bricks and mortar university hospital and you spend part of your rotation there, where you do have to pay a fee. They're fairly nominal fees, and you work within the construct that that university has as an inbound elective student, and that needs to be an application from the student. But what we are doing is oiling the wheels of that mechanism so that as much of that opportunity is available to OUM students, so that we maximise the ease of moving through the rotations to get you to graduation in a timely fashion.
Thanks, Paddy. So you mentioned the 56 weeks of core rotations. Did you want to talk a little bit about elective rotations? What's the recommendation for how Australian students should spend their elective rotations?
Yeah, it wasn't so long ago that the elective rotation, one of them was to go and spend your 4 weeks in Samoa. We've done some more work around that, and you are able, if you wanted to spend quite a long time in Samoa, as long as you don't do from Australia and New Zealand more than half your rotation, your core rotations in Samoa. For the electives, it's really, this is your opportunity to explore the things you think you might want to end up practicing, basically. So that if you want to do surgery, if you want to do emergency medicine, then that's where you might go to say, yes, I'm interested. That's where I want to go and spend some elective time to see whether that's where I want to go, or I want to upskill. So as soon as I've graduated, I can start moving in that direction. The other way an elective can be used is, I'm not very good at cardiology and I don't get this ECG stuff. It just confuses me. I think I'll do an elective because I want to be a GP, and therefore I'm going to have to know a bit more about this. So you can use it to pursue your interests, and it's a very valid use of pursuing those things where you think you need to be upskilled. And occasionally we need to impose upon students a selective, as in the elective is done by direction from the university because it's perceived that you do need some enhancement of the skills in that particular subspecialty.
So you mentioned that students can do their rotations in Australia, and you mentioned some of the hospital systems, and that they're able to do a set of rotations in Samoa as well. We have a question from Kirby who asks, as an Australian student, can we do rotations in the other areas that OUM serves, New Zealand, Canada, or the USA?
Yes, indeed. And they would be particularly the electives. We haven't been asked that question about the core rotations before for New Zealand. The answer would take the question on notice, but the answer is likely to be yes, because of the similarity between the healthcare systems in Australia and New Zealand. And again, I'm not sure we've had the cross-jurisdictional rotations in the way that's been asked by Kirby. And so take the question on notice, but a positive reflection on the idea of having that sort of cross-fertilisation. We are actually dealing with, we have a Brazilian New Zealand student who we're working with at the moment to explore doing rotations in Brazil. And we have a student in Melbourne who is having to move to the Middle East for a significant period of time of their clinical rotation expected time. And so we're exploring that, but at the moment there's sort of questions on notice rather than a guarantee that we'd be able to go in that direction.
I want to talk a little bit about the OSCE, which is kind of where we started this conversation. So a good place for us to come full circle. And there is a question from Akane about, where we do our OSCE, how long does it take? So Dr. Mountford, would you like to talk a little bit about the OSCE? Why do OUM students do an OSCE? What is that? What's the value of doing that? And where is it?
It's in Brisbane at the moment. It's usually held once every 3 months or thereabouts, depending on the number of students we have who need to do the OSCE. So basically, to do the OSCE, you have to have completed your full clinical rotations, have them all out of the way. You don't have to have done your FCE at the moment. You can choose to do the final clinical examination after the OSCE, but you do need to have your journal club right up to date, and you do need to have your number of grand rounds that you have appeared at up to date too. They're big things that you do need for your OSCEs. It is better for you to have done your research assignment and had it published before you do the OSCEs, because the OSCE is nearly the end of the road as far as OUM is concerned for you. So the simple fact of the matter is, if you pass the OSCE and you do very well at it, but you have not done your research properly, you cannot graduate from OUM as a doctor until your research is published. So, make that very clear in your own mind. The OSCE is the end for the vast majority of people, because all the prior work that needs to be done has been done. Everybody who's involved in medicine, paramedicine, nursing, and other professions basically do OSCEs as their final exams as part of their course. The reason for this is that if you want to assess somebody to see whether this person is going to be a good intern, now that's what the OSCE is all about. It is about whether you are good enough to be a safe and effective intern. And our examiners ask themselves the question. There's things we look at. We look at the way you approach key issues. We look at the way you actually conduct the consultation with the patient. How you ask history questions, how you do examinations, things like that. There are critical errors that are involved. If you don't think of this, or if you don't think of that, and your patient could be at risk because of it, well, then you can fail the site. But in general, what's required is that we need a lot of that analytical stuff where we can tick boxes and say, yes, you thought of this and you thought of that. But there's that subjective sort of thing that we need to say, yes, this person would be a safe and effective intern. And the other question some of the examiners say, would I let this person be a medical practitioner to a member of my family? And if the answer to those questions is yes, you've passed your OSCEs, okay? You've passed that case of the OSCEs. There's 16 cases to go through. Each of them are 10 minutes, 2 minutes of reading what the case is about, and 8 minutes of actually performing the case. So in that regard, it's similar to the AMC1 exam. The AMC has, I think, 14. They don't mark 2 of them. 2 of them are used for actually seeing whether it's a good case and whether it works and whether it gives a result that we want. We could start doing that very soon, but you have to realise that doing an OSCE, I was talking to one of our team the other day, and preparing for an OSCE and getting all the paperwork ready requires 700 pages of printing. So they're a big thing. They're done over one day. They start at about 9 o'clock in the morning. By 4 o'clock in the afternoon, you're all done, finished. You've finished all your cases. We have a post-exam interview where we tell you your results and we tell you what you need to do from then on in. So that's probably the OSCEs. There are online resources you can actually look at to practice OSCEs. In OUM, we have a thing called the OSCE Prep Course, which you can do. It's free of charge, Monday nights, every Monday night. And we look at cases and we do cases that students bring along. And it's well worthwhile doing OSCE Prep, starting at about 8 weeks, probably before you're going to sit for your OSCE. And we will teach you exam technique, but we will certainly buff up all your rough edges as far as your clinical skills are concerned.
Thanks, Dr. David. As we wrap up our hour together, I wondered if you would like to share any advice you have. We have a number of attendees today who will have gotten their application in by our March 1st deadline and are preparing for interviews. Is there any advice that you would give individuals who are joining us today who are prospective medical students about starting their medical student journey? And we'll start with you, Professor Paddy.
Yeah, a strong word of advice is that enjoy the journey. But one of the things that you need to understand is that medicine is a different language. So if you want to become good at medicine, you have to practice the language, and therefore developing the groups that Dr. Mountford talked about before, of having a collective of students in which you're interacting. So it's not just in the space of the online university, it's not just in the clinical space of the rotations, but you're practicing that language and its interpretation and use with your colleagues along the way, so that you learn to use that language. And just accepting that medicine is an art, it's also a performing art, so that when you're doing your OSCEs, you're on stage. You have to have rehearsed, you have to have got the maneuvers right, and it is a performing art. Entertain the examiner as well as thrill them with your knowledge, but it is a performing art. And when you're working as a clinician, you are also involved in a performing art of entertaining the patient while keeping them safe and while caring for them. But I commend to you, learn the language by practicing the language.
Thanks, Professor Paddy. Dr. David, do you have any parting advice for our attendees today?
I think I'll paraphrase what Professor Mackay generally says to our people that we interview. If you get that piece of paper that says you're accepted, have a second thought and reflect on it as far as your family is concerned, as far as your personal welfare is concerned, as far as your finances are concerned, as far as relationships are concerned, as far as your whole life is concerned. I must admit, I think a lot of the people that we interview have already thought that. I think they come along to the interview and they're prepared. So I suppose the only other way that I could sort of say, well, here I am, 72 years of age. Was it worth it? Absolutely, it's worth it. It is absolutely worth it. It is worth working your tails off for the next 4 years to become doctors. As Paddy said before, the rewards that you get are so much greater than the effort that you put in. They're absolutely related to each other. Don't forget that. You've got to put in the effort. But if you put in the effort and you care for your patients well, you get to my stage of life and you can look back and say, I'm so glad I did that. It was, I've had a wonderful life because of medicine.
Thanks, Dr. David. I know everyone will join me in thanking Professor Paddy and Dr. David for joining us today in their busy schedules and offering lots of food for thought for those of you who have your applications in, and we are wishing you all luck through your interviews. And for those of you who are in various stages of application and getting to know us, we hope you will also join us for our next webinar, which will be on April 11th and 12th, where we'll get to meet an OUM graduate from North America. So looking forward to seeing all of you then. And any questions that we didn't answer, we will ensure we get those answers out to your admissions counselors to ensure that you get a response to those questions. So thanks everyone for joining us. Thank you, Dr. David and Professor Paddy, and see you all again next time.
Bye.
Bye.
Bye.